Welcome back to Minute Med. In this video, we are going to talk about Polycystic Ovarian Syndrome or PCOS. PCOS is a condition affecting many women and it can lead to various metabolic and reproductive issues. PCOS is the most common endocrine disorder affecting women of reproductive age, affecting 10% of women. PCOS is categorized by specific features such as multiple ovarian cysts, infertility, irregular or absent menstrual periods, hyperandrogenism, and insulin resistance. To better understand PCOS, let's explore some key definitions. Anovulation. This term refers to the absence of ovulation, which is the release of an egg from the ovary. Oligoovulation. It means irregular and infrequent ovulation where eggs are not released regularly. Amenorrhea. This condition involves the complete absence of menstrual periods. Oligomenorrhea. It refers to irregular and infrequent menstrual periods. Androgens. These are male sex hormones including testosterone that are also present in females but at lower levels. Hyperandrogenism. It signifies the effects of elevated levels of androgens, often leading to symptoms like hirsutism and acne. Hirsutism. This term describes the growth of thick, dark hair, often resembling male pattern facial hair in women. Insulin resistance is a condition where the body's cells don't respond properly to insulin, resulting in increased blood sugar levels. Now let's talk about the diagnosis. The Rotterdam criteria are used to diagnose PCOS. To make the diagnosis, a woman should have at least 2 out of the 3 key features. Number 1 is oligoovulation or anovulation, which leads to irregular or absent menstrual periods. Number 2 is hyperandrogenism, which is characterized by symptoms like hirsutism and acne. Number 3, polycystic ovaries, which can be visualized through ultrasound or by having an ovarian volume exceeding 10 cubic centimeters. Now, it's essential to remember that the presence of just one of these features does not confirm PCOS, as many women may have multiple ovarian cysts without other PCOS-related symptoms. Now, let's talk about the presentation. Women with PCOS typically present with oligomenorrhea or amenorrhea, infertility, obesity, which is seen in about 70% of PCOS patients, hirsutism, acne, and male pattern hair loss. Additionally, women with PCOS may also experience insulin resistance and diabetes, acanthosis nigricans, which is a skin condition categorized by thickened, rough skin in areas like the axilla and elbows, which is often associated with insulin resistance, cardiovascular disease, hypercholesterolemia, which is elevated cholesterol levels, risk of endometrial hyperplasia and cancer due to prolonged exposure to estrogen, obstructive sleep apnea, depression and anxiety, and sexual problems. Let's talk about the differential diagnosis of hirsutism. It's important to note that hirsutism, which is a common feature of PCOS, can also result from other factors such as medications, tumors in the ovaries or adrenal glands, Cushing's syndrome, or congenital adrenal hyperplasia. Let's dig into the etiology. The etiology of PCOS is largely unknown and multifactorial. The genetic inheritance of PCOS is heterogeneous and complex. However, it appears to be inherited in an autosomal dominant fashion. Postnatal obesity appears to be the leading environmental contributor. The pathophysiology of PCOS relates to excess androgen production, and this is usually due to one or both of excess LH production and hyperinsulinemia and insulin resistance. Excess LH or luteinizing hormone is produced and released by the anterior pituitary in response to gonadotrophin releasing hormone or GnRH, which is released from the hypothalamus. This leads to excess androgen production by the ovaries, which can interfere with the normal development of ovarian follicles, preventing them from reaching full maturity. Insulin resistance plays a pivotal role in PCOS. When the body becomes resistant to insulin, the pancreas produces more insulin to compensate. This excess insulin can stimulate the ovaries and adrenal glands to release androgens, contributing to hyperandrogenism. Moreover, insulin resistance can reduce the production of sex hormone binding globulin or SHBG in the liver. SHBG normally binds to androgens and suppresses their function, so reduced SHBG further promotes hyperandrogenism in women with PCOS. High insulin levels can also disrupt follicle development in the ovaries, causing anovulation and the characteristic appearance of polycystic ovaries on ultrasound. Most women with PCOS have these cysts found in their ovaries. These are immature follicles which have had their ovulation phase arrested. Let's recap the normal menstrual cycle. In a typical menstrual cycle, several hormones such as follicle-stimulating hormone and luteinizing hormone regulate the maturation of ovarian follicles. When the LH level gets really high or causes a LH surge, it tells the ovary to release a mature egg. This surge in LH is like a starting gun for ovulation. With this LH surge, a mature follicle releases an egg during ovulation. After ovulation, the remaining follicle transforms into a structure called the corpus luteum. The corpus luteum is a temporary endocrine structure formed from the remnants of the ovulated follicle. It primarily secretes progesterone, a hormone crucial for preparing the uterine lining for potential pregnancy and maintaining early pregnancy. In individuals with PCOS, hormonal imbalances disrupt the normal menstrual cycle. Elevated androgens can inhibit the development of ovarian follicles and prevent them from maturing sufficiently for ovulation. Without a mature follicle, ovulation does not occur, leading to chronic anovulation. In the absence of ovulation, there is no formation of the corpus luteum, and as a result, there is inadequate production of progesterone in PCOS. Low progesterone levels affect the uterine lining, making it less receptive to implantation and can lead to irregular or absent menstruation. So as you can see, it's all a vicious cycle. There are several differentials to consider in a patient with suspected PCOS. PCOS can present similarly to other endocrine disorders including thyroid dysfunction, congenital adrenal hyperplasia, Cushing's syndrome, and hyperprolactinemia. Let's talk about the investigations. The relevant bedside investigations include urine HCG to rule out pregnancy as a cause of menstrual disruption and capillary blood glucose. Diagnosing PCOS often involves blood tests to measure hormone levels including testosterone, SHBG, LH, FSH, prolactin, and TSH. Hormonal imbalances such as elevated LH and a high LH to FSH ratio, increased testosterone, and raised insulin are typical findings in PCOS. But the key thing to remember for exams is the raised LH and the raised LH to FSH ratio. Pelvic ultrasound is useful to visualize the ovaries, where multiple developing follicles may appear as a string of pearls around the periphery. The diagnostic criteria are either 12 or more developing follicles in one ovary or an ovarian volume of more than 10 cubic centimeters. However, pelvic ultrasound is less reliable in adolescents for diagnosing PCOS. The screening test of choice for diabetes in patients with PCOS is a 2-hour 75-gram oral glucose tolerance test or OGTT. An OGTT is performed in the morning prior to having breakfast. It involves taking a baseline fasting plasma glucose, giving a 75-gram glucose drink, and then measuring plasma glucose 2 hours later. It tests the ability of the body to cope with a carbohydrate meal. And the results are given below for impaired fasting glucose, impaired glucose tolerance, and diabetes. Now let's talk about the general management. Managing PCOS involves reducing associated risks including obesity, type 2 diabetes, high cholesterol levels, and cardiovascular disease. Strategies include weight loss, adopting a low glycemic index calorie-controlled diet, regular exercise, smoking cessation, and appropriate use of antihypertensive medications and statins as needed. Patients should be assessed and managed for the associated features and complications such as endometrial hyperplasia and cancer, infertility, hirsutism, acne, obstructive sleep apnea, and depression and anxiety. Weight loss is a significant part of the management of PCOS. Weight loss alone can result in ovulation and restore fertility and regular menstruation, improve insulin resistance, reduce hirsutism, and reduce the risks of associated conditions. Orlistat may be used to help weight loss in women with a BMI above 30. Orlistat is a lipase inhibitor that stops the absorption of fat in the intestines. Let's talk about managing the risk of endometrial cancer, which is very important in PCOS. Under normal circumstances, the corpus luteum releases progesterone after ovulation. Women with PCOS do not ovulate or ovulate infrequently and therefore do not produce sufficient progesterone. They continue to produce estrogen and do not experience regular menstruation. Consequently, the endometrial lining continues to proliferate under the influence of estrogen without regular shedding during menstruation. It results in endometrial hyperplasia and a significant risk of endometrial cancer. So, women with extended gaps between periods or abnormal bleeding need to be investigated with a pelvic ultrasound to assess the endometrial thickness. Cyclical progestogens should be used to induce a period prior to the ultrasound scan. If the endometrial thickness is more than 10 mm, they need to be referred for a biopsy to exclude endometrial hyperplasia or cancer. Options for reducing the risk of endometrial hyperplasia and endometrial cancer are Mirena coil for continuous endometrial protection, inducing a withdrawal bleed at least every 3 to 4 months with either cyclical progestogens or combined OCP. When it comes to managing infertility, weight loss is the initial step for improving. Losing weight can restore regular ovulation. A specialist may initiate other options where weight loss fails. These include clomiphene, laparoscopic ovarian drilling, and IVF. Metformin and letrozole may also help restore ovulation under the guidance of a specialist. However, the evidence to support their use is not clear. Ovarian drilling involves laparoscopic surgery. The surgeon punctures multiple holes in the ovaries using diathermy or laser therapy. This can improve the women's hormonal profile and result in regular ovulation and fertility. Women that become pregnant require screening for gestational diabetes. Screening involves an OGT test performed before pregnancy and at 24 to 28 weeks of gestation. When it comes to managing hirsutism, weight loss again may improve the symptoms. Cosiprindiol is a combined oral contraceptive pill licensed for the treatment of hirsutism and acne. It has an anti-androgenic effect, works as a contraceptive, and will also regulate periods. But the downside is a significantly increased risk of venous thromboembolism. For this reason, cosiprindiol is usually stopped after 3 months of use. Topical eflornithine can be used to treat facial hirsutism. It usually takes 6 to 8 weeks to see a significant improvement. The hirsutism will return within 2 months of stopping this medication. Other options that may be considered by a specialist experienced in treating hirsutism include electrolysis and laser hair removal. The combined oral contraceptive pill is the first-line treatment for acne in PCOS. Cosiprindiol may be the best option as it has anti-androgen effects. However, there is a significantly increased risk of venous thromboembolism. Other standard treatments for acne include topical adapalene, topical antibiotics, and topical azelaic acid 20%. So, in nutshell, PCOS is the most common endocrine disorder affecting women of childbearing age and is diagnosed using the Rotterdam criteria. The causes of PCOS are unclear but are related to elevated levels of androgens with or without the presence of cysts on the ovaries. The most common clinical symptoms include hirsutism, infertility, acne, menstrual disturbances, and weight gain. Management of PCOS includes lifestyle changes such as weight loss and exercise, as well as pharmacological measures such as COCP, clomiphene, and metformin. Thank you for watching. Show us your support on Patreon, subscribe for similar content, and click that bell icon. Don't forget to check out this playlist and follow us on Facebook, follow us on Instagram to stay tuned. Minute Med, where medicine is made fun.